All right, good evening, everyone, and good morning, United States of America. Once again, BITS Institute of Physiotherapy is bringing to you a webinar. Now, today we have an international webinar for you all. I welcome you all on behalf of BITS Institute of Physiotherapy. I present to you our resource person for today, Dr. Karthik Yadagiri, sir. Sir, I welcome you on behalf of BITS Institute of Physiotherapy and BITS Studio Campus, Vadodara, India. Let me introduce Dr. Karthik for you all. Dr. Karthik Yadagiri, sir, has done bachelor's in physiotherapy from India, and he pursued his master's and doctorate of physical therapy in United States of America. He is a clinician since 15 years with sports, manual therapy, research, and pain science as his expertise. He is a well-recognized clinician with several certifications. Sir has presented over 100 courses and currently works as clinical specialist in DMC RAM, which is one of the topmost hospitals in United States of America. Sir is CEO of IPTA. His hobbies are to play tennis and also being a therapist, he also likes treating sports injury patients. Sir, I welcome you again on behalf of BITS Institute of Physiotherapy. Over to you, sir. Sir, sorry to interrupt. I would like to request the audience to please turn off your mic and cameras. For viewing the presentation, please click on my ID, that is Rushikesh Joshi. Please pin it so you can see the PowerPoint. The question answer session will be at the end of the presentation by Dr. Karthik Yadagiri. Right. Over to you, sir. Dr. Karthik, please.
Well, hello, everyone. Glad to be here today. And this is a very interesting topic, and I'm pretty sure everybody is familiar with the word pain. So, given the time constraints, I'd like to keep it very short, but at the end of the presentation, I want you all to get something out of it, which will be very meaningful and will have a great emphasis or importance in your clinical management of your patients. So again, next slide, please. Rushikesh has already spoken about me. There's nothing much, but I do want to say that RIM stands for Rehab Institute of Michigan, and it's one of the top hospitals. I'm glad to be there. And next slide, please. Next slide, please. All right. Before I move on to the presentation, I would really like to emphasize that I am really fortunate enough to be associated and have worked and being mentored myself from one of the top people in pain science, especially Mr. Adrian Love, who is currently one of the top researchers in pain science. I'll mention the other names as part of the presentation, but I've been fortunate enough to work closely with him, been to a lot of courses and presentations myself with him, and I presented a lot of courses on pain. And I would like to thank MD Education and my hospital, Rehab Institute of Michigan, and definitely all my teachers for being very supportive in giving me this track of being expertise in pain. And on top of that, I would like to thank BITS College of Physiotherapy or the Institute of Physiotherapy for giving me this opportunity, and especially Dr. Rushikesh Joshi. So, next slide. Well, what are our objectives today? Because our time is short and the topic is vast. We can talk about this topic for days. It will never end. But again, I want you to learn something to be unique and important, the way you think about how you manage your patients. So from this presentation today, you should get a little bit of an idea, like how we understand pain. We also need to understand, is pain always because of an injury or disease? And we also learn what are the different ways or a better approach to talk about pain neuroscience education. And we'll have a small segment about neuroplasticity where you get kind of an idea what it entails. And also you'll be able to apply this information into your practice. So that's the goal of this presentation today. Next slide. So we have to all understand the important thing is we are all familiar with pain. The key thing is it's nothing new to us. We have been managing pain. But what we are having struggle or having difficulty with is chronic pain. We all go to managing grade 2, grade 1 ankle sprain or a post fracture or something with an injury, acute pain, something hard to deal with. Very different, and the numbers are growing tremendously. From the 2017 study, it shows that 1 in 3.5 people will have chronic pain. And it's no different across the world. In Australia, it's 1 in 4. Europe, it's 1 in 4. And India, it's almost, I think, 1 in 6 people will suffer from chronic pain. Just in the US, there are about 90 million people who suffer from 9 million people who suffer from chronic pain. So as you can see, it's a great burden. It's a big burden on us that we need to manage these patients because they're not easy to manage because we understand pain very differently. So the key is we need to understand pain in a broad way rather than just thinking of just a symptom. Next slide, please. I put this picture up to see that this is who we are. The guy in the red is us trying to fight against everybody. So I put this picture to kind of get you an idea of, to talk about us. We go into the clinic and treating patients. It feels like we have a lot of struggles to deal with. So moving to the next slide, I'm going to talk a little bit about you guys. So you might be seeing a lot of patients in your clinic and you have a busy schedule. And on the one side, you have a lot of patients, but few of them are not happy because they still have pain. Your colleagues are not very happy with you because you're not getting the best results they were thinking you would deliver. And your bosses are not happy because the patient, you're not feeling enough and you're not able to do what you need to do to manage these patients. The insurance company is not happy because the patient keeps coming back and you have to keep paying for it. And the doctors are not happy because they have to keep sending the same patients, but the symptoms or the pain is not resolved. And you're at the end of the day, you're just tired, you go home, and your family is just tolerating you because you have a lot of stress to deal with it yourself. Put this slide because we have to understand that we as therapists deal with pain differently and the situation differently. And you'll understand why I'm putting this up there. Next slide, please. So pain and its complexity. It's a very interesting situation that 15 years ago, when I started treating patients, I thought everything has a reason and a pathology. You have a pathology and you have pain and you do certain things, manage pain or treat pain, and it will go away and everything will be fine. But over a period of time, I've learned that I've done the same thing for the same condition, but the results are different. Some people get better, some won't get better, and some people actually get worse. So I'm like, it's the same diagnosis, same condition, and I'm treating with the same thing that I used to for everybody, but it's not the same result. So when we dive into it, we started to understand pain differently. So today, I want to give you examples for the perspective of how you see things in your clinic. I'm pretty sure that you're all familiar with pain, and pain is being the biggest driver for patients to come to you. I'm pretty sure nobody comes to your clinic saying that I feel awesome today, treat me. And we all can appreciate pain, but also I put a chart up there of a patient. We'll talk about that patient. As you can see, she's marked a lot of places. So we'll go back to the pointers later, but if you look at the picture, you'll see a lot of areas are marked where the symptoms of the patient are. So move to the next slide. So this patient's name is Susie, and this is not a made-up patient. This is one of our patients that we see often. So from the picture, if you remember, a lot of areas are marked. If you're a new therapist or starting out, you're thinking, oh, where is this area? What dermatome it is, what myotome it is, or what sclerotome it is. But it's more than that. you cannot pinpoint or figure it out because it's pretty much everywhere. By the way, she comes on a Friday evening. She's late, by the way, and we give her a body chart to fill out, and she said, "I need more ink," which means she wants to fill out a lot of area. She's like, "I'm out of ink." She's already seen many providers by that time. She's seen like 8 therapists, 6 chiropractors, 2 osteopaths, like 10 doctors. She still has the pain. She's already been through epidural steroid injections, radiofrequency ablation, and also a lot of stabilization from a lot of therapists. And she's got a lot going on. She also does say that her stress increases her pain. And she definitely has a story. So let's see what her story is. Next slide, please. So keep that in mind. Susie is a middle-aged lady, about 46 years old. She's overall healthy. She has a diagnosis of fibromyalgia, whatever that means to you guys. You can quote the 1,400 points from the Fibromyalgia Association and all, whatever that means to you. We'll talk about that. And she had this pain for over 3 years. No acute injury. The pain is spreading. It has good days and bad days. Pain comes and goes. It has a mind of its own. And you all have seen this kind of patients. And she has sleep problems. She's not able to sleep well because of pain. She even stopped cooking for 20 minutes because if she cooks over 20 minutes when she stands, she has pain for a lot of hours. So kind of she's hesitant to do even cooking for more than 20 minutes. So let's move on with her story. Next slide, please. She can't sit over 60 minutes. She's like, if I sit over 60 minutes, my pain gets worse. I just don't want to do it. She has to keep moving all the time. She's not comfortable. We gave her an ODI scale, which is Oswestry Disability Index. And look at the score. It's not a real score, but she scored horrible numbers, which is like the top of the line. The governor is going to give a record for her. And we gave her the FAQ. If you don't know what it means, it's a fear avoidance relief questionnaire. Then she got a national record in it. She's got numbers off the charts. The governor will give her a certificate of the best record ever, just to be funny. Anyway, her general health is good. She used to work out before. She used to do Pilates and all that stuff before, not at this point because she thinks movement is going to make her hurt. She has no specific joint issues. She does have a family history of low back pain, and she's currently not working. Her husband is a physician, and she used to be in the front office where she used to help them out. But now she's not working because she thinks if she sits over 60 minutes, it's going to hurt, and that's why she's not working currently. Next slide, please. This is the slide you want to see. Susie has decided that if I move, it's going to hurt because when she moves, she feels pain. So she thinks if I stop moving, she will stop hurting, which means she thinks, okay, if I don't move much, I won't hurt. So this is something she started believing in. I want you to kind of focus on this slide and see what people think and what people see and what they perceive with movement. It's very important that you understand this. Now that we know the story of Susie, we can move on and see how we can figure her out. Next slide, please. But we all know we have gold level evidence. There's many systematic reviews that say and have proven that exercise is the best thing you can do, or movement is the best thing you can do. I don't like to use the word exercise because it's very different for each person, but I would say movement of any sort is excellent for people who treat chronic pain or pain in general. And there's gold level evidence for it. But again, Susie thinks if I move, I'm going to hurt. But we know that moving is actually what makes the pain better or tolerable. Next slide, please. So we do a physical exam on Susie. We are very good at this. We do a great physical exam. We check her flexion. We say, Susie, bend down. She bends about 20 degrees, and not even, I think she was 10 degrees, and she's, I'm hurting. Going to extension, 10 degrees, she hurt. SLR hurt. Slump is positive. Top patient, as you can see, she hurts everywhere, top, head to toe. And when you look at her core contractions or core control, that looks horrible. So why do we have to look at all this? Kind of give a perspective of what Susie is going through, but does not tell us what's happening. Next slide, please. So before we move on with Susie's story, This is the most important thing we need to know. Any patient who comes to us, especially they come for pain, majority of them come for pain and some for performance in my field anyway. But majority of patients seek our help for pain. Louis Gifford put 4 things. By the way, there are 4 people who are the ones who've done most of the research on pain, and one of them is Louis Gifford. Laura Marmosi has done most of the research on pain, and now Adrian Love, Dendron have added on, and they're adding more to the research. So this is the key thing. He added 4 things with any patient who comes to us. Every patient wants to know what's wrong with them. If you can't tell them what's going on with them, they'll go to somebody else. They want to know how long their problem will take or their issue or diagnosis to resolve. That's what they want to know. And the other thing they want to know is what can the patient do for themselves to treat their condition or make them feel better. They also want to know what can we do for it. And the biggest important factor they have added as the time went on is the 5th part, which is not before, is how much does it cost. So for any patient you see in your clinic, these are the 5 things that any patient wants to know to get better. Next slide. So what's wrong with Susie? Do you have enough ultrasound gel to treat her? Are we going to do ultrasound everywhere? Do you have enough electrode to treat her? I put that as a joke and rhetoric, but we're not going to use those things anyway because we know those things are not going to help Susie. So now moving on to understand Susie, this is very important. There are about 5 slides in this presentation. We all should really, really think about it and have a close attention and get the most out of this presentation. So this is one of them. The most important thing you have to know is we are movement specialists, which means we do a lot of manual therapy or interventions or manual therapy based or a lot of other modality based and things that we do. But guys, even if you're the next Jeff Maitland or the Tim Flynn or the next woo-woo or guru, the thing you need to understand that pain is very complex. And we'll talk about that how. Before we do any of those manual treatments, you have to understand the 3 top things which are in this slide. The cognition, the beliefs, and the fear system of that particular patient. Before we treat or dive into a movement-based treatment, these 3 things are very important because if we don't address them or if we don't emphasize on them, you're not going to be a successful therapist or you will be able to treat your patients better. So because the one quotation I love to see in my clinic everywhere is that the fear of pain is worse than pain itself. And we all know that. Because a lot of people think that I have a big problem and they're in a lot of pain because they're in fear state. And we'll talk about the cognitions, beliefs, and fear in the next slide. Next slide, please. So let's talk about fear. A lot of my students ask, but I'm not a psychologist. Should I be talking to my patients a lot? I just like to do things. I just like to do my manual therapy. But as I said before, if we don't address these things, we will never be able to get our patients to the better state, especially our chronic pain patients. So can we do this in our acute pain patients? Absolutely. Because if we don't put this information or education, it can lead to chronic pain anyway. So what is fear? It's a distressing negative sensation induced by perceived threat. So it is very important to understand the word perceived threat. It's what the person believes is a threat or what your brain thinks is a threat is going to lead to the fear. Catastrophization is another term very important that we understand. It's like, oh, I have a bulging disc. I'll never walk again. People believe that, oh, I cannot bend again. I cannot lift anything. I cannot work out. I cannot do this. I cannot do that. These are a lot of things which people start to believe by not knowing the true extent of the condition. The most important thing is the fear avoidance model. Dr. Joshi, somebody's saying they can't see the slide, so I'm not sure if it's. Oh, go back to the slide. Okay. So it's very important that with any injury or any pain experience, you can take two routes. You can either go to a fearful route or no fear route. We hope that most of our patients take the no fear route, but it is based on a lot of things, their cognitions, their beliefs, and their experience. Because the fact is, all about the emotional overload. We call it also known as our life. Life happens. You know, a lot of things go on. You're stressful at your job, your family situation, your financial situation, friends, social stigmas, and a lot of things can lead to a lot of different things. So that is what is life is. So how you know and what is the truth, how you find out about it is going to change your pain experience. So important thing is your terminology. I emphasize this to our novice clinicians a lot. We're so up with anatomy because patient comes to our clinic asking about what's wrong with me, and we teach him anatomy. Patient says, I'm hurting in my back. And what we do, we take out the big spine model and say, hey, this is where your facets are. This is where your discs are. This is where your nerve roots come out. This is what happened. And this is where your pain is. And this is how bad it is. And we use the word saying, it's torn, your ligaments are torn. They're stretched out. Your discs are bulging. You have a very bad arthritic joint. So that terminology is set to put not only a bad idea in a patient's brain, you actually add fear to their condition, because we know for a fact that those things might not be the reason at all, because a lot of times we don't even know what causes the pain, and pain is very different. We're going to talk about that today anyway. But it's important to know that what you speak can have a grave influence on one's pain experience. So is it just injury or pain? They're two different things. Of course, person can have pain because of an injury, but it is not always because of an injury, because a lot of our patients who come with chronic pain who never had an injury, no acute injury at all. They started feeling pain one day, or they woke up with pain one day, and it's been there for a while. It's been there for 3 years, 5 years. In our case with Susie, it's been there for 3 years, and she had no acute episode of pain. So we really need to understand that saying the words, trying to figure out the words that are catastrophic to the patient can be very dangerous for the rest of their pain experience for the remainder of the time. Next slide, please. So this is critical, because we all know, we all should know, if I had to ask the question, this is what I ask my students: where do you think the center of pain is in your brain? Because we know for every task, we have a center in our brain. For thinking, reasoning, conscious memory, problem solving, for sensor discrimination, the motor planning, for everything, we do have an area that the brain is focused on or has a center. But for pain, all of you might be thinking in your head, okay, where's the center for pain in the brain? There's none. There's no center for pain in the brain. It's not like this is the area. I'm glad there's none, because the surgeons would have tried to remove it. But we all know pain is very essential to life. Without pain, we all will be dead in about less than 24 hours, because pain is the biggest signal that tells our body something is going on. So in the next 3 slides, you have to see that each area of your brain has a task to do. For example, your premotor cortex organizes and prepares you for specific movements. Your cingulate cortex helps you in concentration and focusing. I'm not going to go through each of them, but as you can see, each area of the brain has a job to do. To put it in plain perspective, if you have an office, everybody has a job. You have an accountant, you have a janitor, you have an administrator, you have a project manager, a lot of designations, and everybody has a job to do. Next slide, please. So same thing again. Each area, including your cerebellum, hippocampus, spinal cord, all of them have a job to do. So what does this got to do with pain? Next slide, please. This is the most important part, right? You are interacting with all these centers when you have pain. Every part of your brain is occupied. Now we can see this on the PET scans, the MRIs. What they have done is, if somebody is in pain, a lot of these areas light up, which means the person is so busy. Think of it this way. You're in a busy office and terrorists are outside your office. What do you think is going to happen? Is everybody going to sit in the office relaxed? Is everybody in the office going to say, hey, it's okay, the terrorists are going to come, kill us all, it's okay? No, we're all going to be in an excited state. If somebody comes, the administrator comes to the accountant and said, would you print me the statement for the last year? Do you think he's going to do his job at that point of time and think there's a terrorist sitting outside? Probably not. At that point of time, everybody's in a meeting figuring it out. What are we going to do to survive this? Because that's the priority. So that's what happens when somebody has pain. All the centers of our brain are in a pain meeting. They cannot focus on their job. That's why people in chronic pain have issues with digestion. They get infections often. They cannot sleep because they're in a heightened state. They have issues with concentration. They have issues with short-term memory. They have issues with motor coordination or motor planning. So these are the questions we typically ask our patients, because we know when they're in chronic pain state, all the centers of the brain are focused on pain and they cannot do their job efficiently. Now, let's say the threat is gone. Everybody thinks, oh, the people who are standing out there are not terrorists. They're just doing a movie set. Then your threat level went down. You know what's happening there. Then everybody can go back to their job. Now, if the administrator comes and asks, okay, print out a statement for last year, then he'll be say, that's fine, no problem. So he can go back to his specific job efficiently. That's the key part. When somebody has pain experience, they're not going to do a good job in many areas, and we are not going to change that till we explain them or bring that threat level down. So as you can see, there are a lot of things that happen when you have a pain experience, and we add to it. Like you can see, physical therapy is part of it, and the therapist is part of the pain experience. If the therapist says, oh, you have very bad muscles, you have very bad weakness, you just a bad joint, all those things that the therapist puts in the pain experience of the patient can definitely alter the results of the pain experience the patient is going to have for the next coming years. And what the patient believes is very important. He thinks, I'm never going to get better. Or if he thinks, till my pain goes away, I can't do anything. So all of these things happen because not just because of injury to the tissue, because we know the tissues heal no matter what. But even if the tissue is fine, or there's no issue with the tissue, you still have pain. So pain and injury and pain and pathology are two different things. So that's where we need to understand from today's presentation. They're two separate things, and you have to see them separately, not put them together all the time. Next slide, please. I put this slide up there. This will take a lot of time, but I want to give you an idea that when you are in that painful state, which is like the lion in the room, you're not going to sit and relax. If a tiger is chasing you, if there's a lion is sitting next in your room, though it's from the zoo, you're not going to sleep. You're not going to relax. You're not going to digest your food. Your adrenaline is going to rush in your body to fight or flight. So that is very important. Pain is like the lion in the room. We always complain. The patient is very lazy. He won't do anything. I tell him the exercise program. I tell him to do this, do that, but he won't do it. We always complain, because even myself used to say, these patients are just fraud, malingerers. They're lazy. We've called them many names. But again, shame on me and shame on us. Now I'm a champion for these patients. Now I support these patients because they are going through a different pain experience. That is very important to understand, because in chronic pain, all of these issues will be different. As I said, your memory, libido, your ability to cope with things, sleep, big factor. Sleep is very important because there is a biological change when this is present. I put some information that will take a lot of time, including your endocrine system, your immune system, immunoglobulins. Everything is going to be altered when you are in constant pain. Pain is important, but being in pain every day is not good. Next slide, please. So if you want to get anything out of this seminar today, this is the slide. This is something we use pretty much every day on every patient who's in chronic pain. This is how you explain patients about pain. We have to really understand that, as you can see, your nervous system is always at an excited level because it's always taking information from outside and within to make sure everything is working appropriately and normally. We always have certain level of electrical activity. So if there's an input to the system, and if it goes beyond a threshold, we will experience pain. And it's important because if you are walking down the road and if you step on a rusted nail, we all want to know about it, right? Otherwise you'll bleed, get infected, and die. We all want to know about it. And the only way we know about it is you have pain. So that way you can quickly take your foot off of it and not get infected. So it's very important that there's a normal exciting level of the system, which always is receptacle, which means it's always taking information. And once it finds there's a threshold, something is bothering it, and then it goes up and you feel pain. So as you can see in the first one, if I can point this out, if you can see, this is how a normal person or person with less pain or a manageable pain or somebody who's not in a lot of pain is going to be in this state. Because we know there are about at least 6 miles of nerves in our body, right? So we are always taking information. We have a lot of room, which means you're jumping, you're moving, you're running. Those things don't bother us. And only if somebody takes a pin or a knife or pokes, you go to a threshold, you feel the pain. Now with chronic pain or with somebody who's in a painful state all the time, this is what happens. And these are things you show to your patients and they understand it, they get it. They know because pain is a sensor. It's this. And now what happened is even a little bit of input to the system leads to pain. So your threshold has become very small. So the room to do things, you used to run for 6 hours, 4 hours, 2 hours before. Now you can do it for 20 minutes and you feel the pain. So your ability or the room to do things has become very small. And that's what changes with pain, with chronic pain or excited state. And most of the time, now that we know from research that chronic pain patients or your patients who are in pain a lot of time are in this state where the nervous system is in excited state, even with the little information or little emphasis or the threshold level is dropped so much. So our job is to figure out how do we drop this down back here so you have more of a larger threshold so you can do more things, get on with your life and enjoy your life before you start to feel the pain. So this is what we like to show our patients. We tell them, we educate them, tell them that it's okay. You know, you used to be like this, you became like that because your nervous system is heightened, it's excited, it doesn't know, it's always taking every information. The example we typically give them is like you have this security alarm system in most of the banks, right? And every time you go into the bank, no alarms are going off. Everything is fine. But if you see a lot of people coming in with guns and say, then you push the button, the alarm goes off, and you get a lot of cops and everything is happening. But think of it this way. If the sensors were so sensitive that even in the wind blows, the alarms goes off all around the bank, it's nuisance to people, right? You don't want that. You just walk to the door and the alarm goes off. If the wind blows, the alarm goes off. That's what happens. The system becomes so sensitive that for every simple thing, you go to the state where you need to flight or fight. So that is the sensitivity part. Moving on to the next slide. So our job is how do we turn down the alarm system? In our case, Susie, she's like, I have a lot of problems. I can't move because I'm in pain. I cannot do this. I cannot do that. I don't think I can work out again. She's got a lot going on. She has a story. It's important that everybody has a story. We need to understand their story, what they believe in, what their cognition is, what their experience is. All of that plays a part in their pain experience. We don't call it just pain because it's an experience. Because young kids, think about that. So kids fall all the time and they have no pain. Like they fall 10 to 100 times a day and they have no pain because they have no fear. But we as an adult fall once and we're sitting and saying, oh God, it hurts. It hurts for days. If somebody who is not very active falls once and they might not even get up for a long period of time. So it's all based on our experience. What do we perceive that situation or fall is? Like if you had a bad experience before, going to a therapist who did a manual therapy technique, hurt them for days, then they're so fearful, though the technique might be the best technique, but at that point of time led to a bad experience, he will always remember that treatment as a bad treatment. So we need to understand what is their experience, what happened to them, what is their previous history with regards to it. It's not the condition or the diagnosis. They have no role to play, and we'll talk about that in a little bit in examples. So again, our goal is to bring the nervous system to be less sensitive. In a sense, it has more room to play, to do things. Next slide, please. So we all know movement is the biggest painkiller on the planet. But do we tell all patients, okay, now start running about 6 miles because it's equal to 10 milligrams of morphine? No, that is not the idea. But we know that movement is essential. It's imperative. That is our goal. At the end of the day, we want to make our patients more mobile, more functional, so they can get on with their life and start to now worry or think or associate movement is equal to pain. That's the paradigm we need to change. In order to get that, we need to go through the cognition, fear, and belief system. So very important. We need to know. Don't tell your patients to stop moving. Keep rest, rest, rest. There's no evidence unless it's an acute fracture and injury that you need to rest. Even rest, there's a new terminology, active rest. You don't rest your whole body. You just rest the part that is required for a short period of time. The sooner you can start moving, the better it is. Even in ICU, we want the patients to move, right? So movement is very, very critical. That's how the body works. Next slide, please. So before we get to neuroplasticity, let's summarize a little bit about pain. I want to guys give you examples. So let's say you have 3 ladies, Mary, Susan, and Susie. We already talked about Susie a little bit. Susie has chronic pain, right? Mary had pain for about 3 months. She fell from a staircase and she hurt her shoulder. She comes to you and she's very busy, very active, and she's about to get married in 2 days. And she's very happy that she's getting married. Her father planned a gala wedding and she's excited, but she fell, she hurt, she came to you. And now we have Susan, who is a lady who sits at office all day, goes home to an unhappy situation. Her husband is kind of not nice. Her in-laws are telling her to work more because the husband doesn't work. She has to do all the housework. And she lifts a crate or a box and she hears a pop in her shoulder and she feels pain and she comes to you. And let's say our Susie also had an issue. She's been going through this pain cycle for 3 years. She fell from nothing. She just slid and fell on the floor and she hurt her shoulder. She comes to you and all 3 x-rays are normal. None of them have arthritis. None of them have fracture. But each of them has the same diagnosis: strained shoulder, sprained shoulder, whatever the doctor is in the mood for. That doesn't mean anything. Those diagnoses are just kind of guideline what to look for. But at the end of the day, each of them has a different story. I don't want to treat Susan because she's unhappy in her life. She has a lot of things going on in her life that she's not happy about. So this kind of makes it a lot. So let's say she comes to you and you tell her, oh my God, your shoulder looks really bad. You're so weak. If you move your shoulder, it's going to get worse. And she's not going to get better for the rest of her life. Though she has the same condition, but now on the other side, Mary is going to get married in 2 days. So she's excited. She's happy. She has something to look forward to. She's going to brush it off. And when you tell her your shoulder feels fine, everything looks fine, you'll be fine, she will do much better. Why I say these stories is it's very important. I cannot emphasize enough that each person's story actually adds to what you need to do to treat that patient. Because if this patient is Susan, who's going through a lot of these family issues, I'm not going to give her a home exercise program with 10 exercises for her shoulder. It's not going to do any good for her. That's why you need to understand doing ultrasound on her, hot packs, cold packs, electrodes, whatever your choice is, it's of no use. Making sure that she understands that this is not dangerous, it's not going to lead to any problems, everything is okay, is something very critical for this patient to know. Otherwise, she'll get into that fear avoidance model, into the fear side, and she's going to have a bad experience. She'll be on a heightened state to move her shoulder, then disuse and weakness, and the cycle continues where she'll never get better from one episode. So this is very important to understand, that each person's story plays a critical part in their pain experience and in what we do or choose to do. Because that's why we always see, oh, I get this shoulder arthritis, early arthritis, middle-aged women, and some of them do excellent. You've done the same treatment on all of them. Oh, I take this patient, I had great results. It's not because of what you did. You think it is because of what you did. I would like to think it is because of what we did. But the fact of the matter is, those all things are almost either placebo or a little effect, if you look at research standpoint. But what you tell them, what you educate them has a major influence. For example, chronic low back pain is a huge condition that we see a lot. 70% of our caseload is chronic low back pain. And these people think that I have a serious facet problem, serious disc problem. None of those things are that important, to be honest. Your posture is bad. That's the big word that's thrown around every day. Your posture is bad. Your technique is bad. The way you move is bad. Everything is bad. You keep telling these things to the patient, and the patient will stop moving. He thinks, if I bend, it's going to hurt. I'm lifting bad. I don't know how to lift. Or I'm going to lift, it's going to hurt. If I sleep like this, it's going to hurt. So I'm not going to sleep like. Every way you add more fear to the patient, it's going to end up with an experience which is not going to be effective in the future. So we as therapists, because you should know this, most of the research on pain in the last 20 years has been done by physical therapists. Because the pharmaceutical industry does pain research differently because they want to give us a pill or medication. We know what has driven to this opioid epidemic, because people been taking this pain medication thinking that that will solve their problem. It doesn't do anything, because they take the strongest pain medication and still have pain. Because pain is not something just chemical in nature. It's the experience. It's what you believe, what you think is a threat. So at the end of this presentation, if you understand one thing, is start to think of pain differently. Start to know your patient's story, and each patient is different, regardless of their condition or diagnosis. It doesn't matter, because let's say if you have a back pain patient, don't narrow thinking it's just the facet problem or the disc problem, it's the weakness problem, co-contraction problem, motor control problem, stabilization problem. You gotta think globally, because it could be the endocrine problem, immune system problem, in a sense, their perception problem, their fear problem. They don't move at all. They're lazy because they think it's gonna hurt. We need to change that before we make them do your favorite exercises, 10 exercises, 20 exercises, because they're not gonna do it. They're gonna stop and they're gonna go to another provider, because we are so used to doing passive treatments, we don't enable our patients to be doing things for themselves. Because we know movement is the most important part any patient has to do. So I hope you kind of got a sense of how we have to look at pain a little differently. I don't want to go into detail of everything because it's going to take a lot of time. And let's talk a little bit of neuroplasticity. The guys doing research for the last 12 years came up with this term plasticity, because now we know that our brain is plastic. We have a lot of maps in our brain, like we saw different areas do different things. And when we're in chronic pain, they're in a pain meeting, which means there's smudging, which means the brain kind of becomes, think of it as a GPS system. You lived in the neighborhood for a long period of time. You go to the bus station, the grocery store, the gas station, or even the school. You know everything around that place perfectly well. Even if with your closed eyes, you can tell everybody where everything is, what color it is, how to go there. But imagine you haven't been there in 50 years or 30 years. You vaguely remember things. You don't know how things are. It's not very clear. When maps are clear, you go quickly to one place, go to another place, you exactly know where to go. So that's what happens when somebody has pain. All these areas of the brain become smudged, in a sense that they cannot differentiate your body parts. They cannot even tell where the back is, where anything is. They cannot discriminate their sensation. They just don't know. Your homunculus, if you remember, has each areas in your brain. You can't really tell what's going on with your body itself. So they have no perception of their own body, because all your systems are busy in a pain meeting. So plasticity is something where you gradually put a patient through step-by-step process to kind of first give them the perception. Because in chronic pain, what they have seen, people cannot figure out difference between right side and left side. If you show these patients pictures of right side and left side, it takes them more than 2 seconds to figure it out which side is right and which side is left, which is easy to do in a clinic. We just give them magazines, tell them mark the right leg or the left leg. Person who's got intact system can quickly go in less than 2 seconds, fast. But people in chronic pain, it takes 6 seconds, 4 seconds, 3 seconds. And their perception of the body parts is huge. They always think their part is inflamed. It's so big, it's just swollen. Though the body part might be perfectly normal shape, their perception is different. So there are different parts we have to go through to change the way the brain sees yourself, to integrate this information to become better, so it's to make the maps in your brain sharp, so that way you do a better job. This can be effective in patients with even acute ankle sprain or shoulder injury, because they quickly can keep the map sharp. The chances of injury are less because they're very well aware of their own body, so they do the right things at the right time, leading to less injury. And we emphasize this in our sports people. Though they come to us just for performance, there's not much pain, but using these techniques to figure out and being very crisp and clear with their maps in their brain gives them an edge. Next slide, please. I want to summarize it that this slide is very important. You can teach your patients. And there are a lot of stories we have come up. The neuro pain science education has evolved a lot. They've come up with short stories which you can tell patients, kind of really calm the system down, and then do your treatments. There's a way to do or go through the neuroplasticity techniques, but this is the most important part. First, you need to talk to them and decrease their fear, not increase their fear, folks. Remember, your language is critical. Please don't show them the red seeping images of their disc, falling out of their bones. All those bad images, they don't help them at all. Your patient didn't come to learn about anatomy. He came to know what's going on with them. How long does it take? And what are you going to do for them? You don't have to throw those bad images, throw those bad information, speak the bad language to increase or heighten their sensitivity. That's very important. Next slide. So I put it all together for neuroplasticity. It's very hard for me to explain neuroplasticity in this such a short period of time, but they've done small experiments. It's still in the evolving state, but now for CRPS 1 and 2, they really got the research done. How do you emphasize? So graded motor imagery, sensory localization. There are a few terms that I'm throwing out there because each one is going to take a long time. But understand this. There are techniques that you can do, that you can apply in your clinic right away to see the change or decrease the perceived threat of the patient. One of them that I like is sensory discrimination or 2-point discrimination. We use just a small calipers, which is very cheap. We tell the patient, can you feel 1 point or 2 point? We've seen this before. People in chronic pain cannot perceive 1 point or 2 point for even like 10 centimeters or larger on their low back. People with no issues, they can figure it out like in 5 centimeters. Within 5 centimeters, they'll be able to solve it's 1 point or 2 point. We can test it on our patient. They will have difference from side to side, which means the brain doesn't know where your body parts are. It doesn't know what to contract. It just grossly does everything. So having the finesse in our body, it's lost when you're in chronic pain. There's motor imagery, and there's a lot of ways you can do neuroplasticity technique. And there's a process step by step that you have to go through in our clinic to get the results. But it's going to take a long time, and it's going to take a lot of time to go through each one of them. But I want you to understand at the end of the day from this presentation, you need to know your patient's story. You need to know there are a lot of yellow flags, blue flags, black flags. We didn't talk about flags, but you don't want to increase the fear of your patient. Change the way they think. Don't let them catastrophize their experience into a bad one, and tell them it's okay. It is not that bad. From all the research we know that our biomedical education has failed us in a sense that we understood pain so wrong. We always believe that there's a pathology behind pain. Sometimes there is pain because of a pathology, but majority of the time, it's not the reason, especially if it's chronic in nature. So start to remember that. Don't tell it's because of arthritis. We don't know it's arthritis. That's the term that's thrown around every day. It's not the arthritis. People with 90-year-old with full arthritis have no pain. Then how do you explain those things? A lot of times, the therapists deal with pain a little differently. Think about this. How many times a therapist who has back pain is treating a patient with back pain? But the perception for the therapist, I have 2 or 3 discs bulging, that doesn't mean anything to me. it's no threat for me. But for the patient who has a bad job, bad home situation, if you tell him you have disc bulge, he thinks my life is done. I can't do anything anymore. I can't work. I can't do my family chores. I cannot help my family because I have a bad disc bulge. So that word itself is going to change his whole pain experience for the rest of his life. So folks, as therapists, it's our job to understand these things about what we speak, what we say, how we educate. Don't think that educating patient with this jargon, medical jargon, which is going to increase their fear, is good for your patient. They didn't come to learn anatomy. It's only to know what's going on for us, but not to make them feel worse after they leave us. Next slide, please. So while that was neuroplasticity summed up, and I would like to take a few minutes that I would like to talk a little bit on neuroplasticity. As I said, it's a step-by-step process. The 4 things we typically do: we first learn about laterality, which means the patient should be able to identify right side or left side quickly. And then we go through the process. We do graded motor imagery, and then we put them through gradual exercise program, slowly increasing their ability to translate or put emphasis on the threshold when they start feeling the pain. We don't make them do too much. Do 2 miles today. No. If they do 20 steps, that's what they do. That's it. So we do graded exposure to exercise, and slowly we kind of make them manage their pain rather than just eliminate. We tell them, your pain is not going to be completely gone. It's okay to have pain. Pain is good for you. Pain is important. Make them feel that pain is okay. So that's the presentation for that. I also would like to discuss something that I've been fortunate with, is about being a doctor in physical therapy and doing doctorate. It has opened a lot of doors for me, because research, the way I see it now, was a lot different when I did my bachelor's in India, because we didn't have any background in research or didn't understand any research terminology. Even people who are doing masters in India, they really don't understand how to. There's a lot of emphasis on specialty, or sports therapist, cardio therapist, or whatever therapist, neuro, ortho. But remember, folks, once you understand research, whatever question you have, you can get answers in the right way and actually be critical in it, so you can get information by doing research. And that gave me the opportunity. That made me better as a therapist by doing my doctorate in physical therapy. At the end of the day, gave me that opportunity to understand things very differently. And that is the current standard in the USA. And I want to tell you guys that if anybody is interested in pursuing their dreams in the USA, or working in the USA, or getting their doctoral degree, we as a team of IPTA worked very, very hard and have partnered with a lot of US universities, and especially University of Montana and Rehab Essentials, to bring the program down to our Indian therapists who can pursue the program right from their home in India, where we're a king, for a very affordable cost, and get the degree from the USA, from a very, very reputed university. And the professors who teach the curriculum are the best in our profession, period. They are the ones who wrote the books on everything. So it's been a pleasure, and it's been a great opportunity. And we have really worked hard to get that done for our Indian fellow community, so that way we can give something back. I teach a lot of doctoral students. At the same time, it's been my mission to bring our standards in our profession, to see us as frontline clinicians. That's been my goal. I want to see us as clinicians, not technicians. Though in India, we are rapidly growing in numbers, but the quality of our education is still kind of not par. I hate to say this, but not on par with the other standards. So we are very good at the bookish language, but our research background, a lot of factors and a lot of modules which we learn in doctorate in physical therapy is not there in India. Even if you do PhD, you're just emphasizing on one small topic, but you're not a well-rounded first-hand clinician. So if you are interested in knowing more about this program, how do you pursue it? How do I get a degree from the USA? What do I need to do to come to USA and stuff like that? We're happy to help you guys out. Please visit our website, IPTAUSA.com, for all the details. And if you need any more information, please do visit the website. Put your information in there, and a team member will contact you to give you more information about it. So with that, I'll close this presentation for today, and I'll be open for questions. Thank you.
All right, that was a very wonderful session, Dr. Karthik. Thank you so much. I would like to ask the audience if you have any questions, please write it down in the message chat box. Audience, you are open for questions. Well, I hope the topic was very clear, Dr. Karthik. You made your points very precise. I really appreciated the way you correlated pain and neuroplasticity. Neuroplasticity currently is a topic which we physios should know, I believe, and the student should know these concepts. So the topic you selected and you're presenting for us, it's really good. I really appreciate, sir. For even I learned few facts. You know, even I understood a lot of points which I never thought of. And the way you explain how pain creates a impression on the minds of the patients, and we need to counsel them uh, before they go to a stage where they don't feel or they don't realize where they're going. So I really appreciate, sir. Thanks for sharing. Any questions, please, audience? All right, I don't see any pop-ups at the chat box, so I guess the topic is very clear to them. I believe.
I hope
Right,
you
sir.
were. I hope I was audible to everybody. And I'm glad if you like the presentation. And there's a lot to learn about pain, and we ourselves are learning more because our first paper came out in '98 and 2003 when we had the official paper in 2003 and 2016. Most of the research is done by physical therapists now on pain, especially the Lorimer Mosley team has done a wonderful job, brilliant guy. And it's very important that we understand pain. We become more of a very focused specialist, but we forget the point that each individual is different and we have to look at it as a whole as opposed to parts. I'm a knee guy, I'm a shoulder guy, I am an ankle guy, I'm a neck guy, I'm a back guy. Body doesn't work in isolation. Every system has to work precisely efficiently for the better results. You cannot take endocrine system, immune system, gastric system, pulmonary system, cardiovascular system out and say, I'm just going to treat the knee. It's not going to work that way. I hope I was clear, but if you have any questions, please go ahead. If not,
Yeah, I guess we don't have any questions till now. So I guess we are ending the session here. I would like to thanks BITS Institute of Physiotherapy team and my management for supporting me to organize this session. My special regards to Mehul Jadhav sir and Dr. Sarfraz sir for always motivating me. I extend my gratitude to the audience for joining us, my fellow mates, my physiotherapists in India, and a few of my friends in America. Special thanks to Gade Dada for designing the flyers and making our work colorful. I once again thanks Dr. Karthik sir and my friend Dr. Ajit sir. I can also not forget you. I hope you are there, sir. Ajit sir. And regards to IPTA team USA for joining us and sharing your knowledge, sir. I hope to see you all again. Thanks, Dr. Karthik.
thank you very much.
Yes, sir. Yeah, hoping to see you soon, sir.
Absolutely.
Have a great day. Yeah. Okay. Thank you, sir. Bye.